the cells which are forming myelin sheath in relation to the central nervous system. So specifically they asked about the central nervous system. So there is a peripheral nervous system and there are different cells which make the myelin sheath around the peripheral nervous system. Okay. So what is myelin? Myelin is a collection of lipid, fats and proteins that sheets along the long extensions of neurons which are called axons. Okay, I think you are familiar with the parts of the neuron. So this myelin sheath that covers the axons, they help in the conduction, faster conduction of the impulses. So it considerably increases the speed of the nerve signals and it helps in fastly spreading the impulses move down the axons. Okay, so this is also a PYQ. They have in this particular question, they are asking about the cells which are forming the myelin in the central nervous system. Whereas in peripheral nervous system, this myelin is formed by the Schwann cells. That's also asked. Okay, so there is myelin sheath that is covering the myelinated neurons, and at certain points this myelin sheath is broken at certain intervals, and that places where this myelin sheath is absent, they are called nodes of Ranvier, and they are rich in sodium channels, and hence impulses move very fast. That's literally they jump from one node of Ranvier to next node of Ranvier. That's due to the presence of rich sodium channels in the nodes of Ranvier, and this particular type of conduction is called saltatory conduction. Okay. So what's the composition of myelin? That's about 80% lipids and 20% proteins constitute the myelin. Now this is the basic structure of the nerves. Okay. This is the dendrites and this is the cell body or the soma. And these are in between areas. That's intervals where myelin sheath is absent. They are called nodes of Ranvier. And in central nervous system, basically oligodendrocytes. They are the cells responsible for the formation of myelin in the central nervous system. Whereas in the peripheral nervous system, they are Schwann cells which are creating the myelin. Okay. So also in vitamin B12 deficiency also there is problems in myelination and therefore tingling sensation etc. can be noticed by the patient. Okay. So another disease that's called multiple sclerosis, that's an autoimmune disease which causes demyelination by the autoantibodies and thereby slowing the impulses to a major extent. Okay. So next is what is the hunger center of brain? Options are hypothalamus, stria nigra, frontal lobe, temporal lobe. So what's the answer? Hypothalamus. So we have to be very familiar with the functions of hypothalamus also. So these are the basic functions of hypothalamus. First and foremost function is the synthesis of releasing hormones and regulation of water balance by the synthesis of what ADH or antidiuretic hormone or vasopressin. That's secreted from the hypothalamus. They are stored in the posterior pituitary that we have discussed in the previous session. And also the control of body temperature and center of hunger, feeding, thirst and satiety. And center for emotional and sexual function. These are all functions of hypothalamus. So satiety century. Satiety means what? The satisfaction component. That means what? When we eat, when we stop eating, when we are full. Okay, that thing of satisfaction is called satiety. And satiety center in hypothalamus, it's basically dependent on, it's regulated by the blood sugar levels. So when the blood sugar levels are low, we feel the emotion of hunger. Okay, like that. And next question, this is also related to this question. The temperature of body is controlled by medulla, precentral gyrus, diencephalon, hypothalamus. So here the answer is also hypothalamus. It's one of the function. Okay. We have already mentioned that control of body function is also a function of hypothalamus. So the answer here is hypothalamus. Now coming to the next question. Middle ear deafness can be tested by. First is Babinski test. Second is Chostek's test. Third is the finger nose test. Fourth is the Weber's test. What's the test? It's the Weber test. Okay. So, Renne, Weber and audiometry are the best tests for the hearing. And basic principle of this tests are air conduction of the sound is better than the bone conduction. That's the basic principle of this test for hearing. Okay. Now, let's discuss about the other tests. First is the Babinski sign. What's Babinski sign? It is positive in infants less than 2 years of age. When it is positive in more than person more than 2 years of age, that's a result of some CNS dysfunction, usually some corticospinal tract damage. Okay, so what's Babinski sign? When we stroke the plantar aspect of our soul of our plant, sorry, in the soles of our foot, when we stroke using a blunt instrument, what happens is the greater toe will be placed backwards and the fanning of the other toes will take place. That's what we call as positive Babinski sign. Okay, so positive Babinski sign is normal under 2 years of age, and it is this when it's positive in a person more than 2 years of age, it is a result of CNS dysfunction. Okay. So, Chostak sign that we have discussed in the previous section, that's due to hypocalcemia. Okay. And this is a finger nose test. It's used for the demonstration of cerebellar dysfunction. Usually, the patient is asked to touch the nose, and after that, he's asked to touch the forefinger of the examiner. And the forefinger of the examiner is moving alternatively, and the patient is asked to touch the forefinger. Okay, this process is continued. Usually, the patient touches the nose first, and after that, the patient has to touch the forefinger of the examiner. Okay. Thereby, we are assessing the cerebellar functions. Okay, so it's a test used for cerebellar dysfunction assessment. Next is also a very important topic, that's basal ganglia. That's our usually repeated MCQs from this particular topic. And the lesions within the basal ganglia produce the following signs except. Okay, so the options are hypotonia, tremor, hemibellismus, athetosis. They're asking except. Okay. So what's the answer? The answer here is hypotonia. Okay, so let's discuss the lesions produced due to basal ganglia dysfunction. Okay, and usually the first thing happens when a basal ganglia is some lesions occurring to the basal ganglia, then we can notice the patient is having usually showing features of Parkinsonism characterized by tremors, rigidity, akinesia, etc. And chorea will be seen. Chorea means dance. Okay, dance-like movements. Okay, irregular and involuntary movements occurring in the body are called chorea. And another thing called Sydenham's chorea is a feature of rheumatic fever. Okay, and athetosis also the same thing, somewhat like the chorea. It's involuntary movement of the body. And hemipallismus means it's also a violent jerking involuntary movement happening to one leg or the arm. Hemi means half. Okay. So either one leg or the arm is affected in hemipallismus. It's showing involuntary rapid movement. Okay. So these are all features of basal ganglia lesions. So another question relating to this topic is tremors are seen in the disorders of basal ganglia, pain pathway, pyramidal tract, parathyroid gland. So obvious answer is basal ganglia. The rest others are also we can eliminate from the options. So the answer is basal ganglia. Next is another question. Hyperkinetic syndromes such as chorea and athetosis are usually associated with the pathological changes in. So this is also due to the dysfunction of basal ganglia complex. Okay. So from this we can frame different questions. These are examples of different questions I can frame from this particular topic. Okay. So coming to the next question. Respiratory center is located in the. Options are medulla oblongata, spinal cord, midbrain, hypothalamus. So we have already discussed about the hypothalamus. So we can eliminate this particular option. So other three options are there. So the answer is medulla oblongata. Okay. So it has different centers that control many vital functions are controlled by the medulla oblongata. Usually they are the respiratory center, vomiting center, deglutition center, and the nuclei of vestibulocochlear, vagus, spinal axillary, and hypoglossal nerves. They are all controlled by the medulla oblongata. Okay. So this is another question. Swallowing center is located in the answer is medulla. Okay. So deglutition center or the swallowing center is situated in the medulla oblongata. And the breathing ceases upon. Okay, we know that the respiratory center is under the control of medulla oblongata, and hence breathing ceases upon the destruction of medulla oblongata. Okay, So the answer is medulla oblongata. Next is chromatolysis. What is chromatolysis? The options are disintegration of nucleus, disintegration of Golgi apparatus, disappearance of Nissl granules. Fourth option is the decrease in cell size. What do you mean by chromatolysis? So the answer is disappearance of the Nissl granules. Okay. So chromatolysis means it's a reactive change due to some stimuli or inflammation like that. That's what we call as reactive change that occurs in the cell body of the damaged neurons involving the dispersal and redistribution of the Nissl substance. That's what we call as chromatolysis. So Nissl substance is present in the cell body of the neuron. Cell body, the other name is soma of neuron. So the reactive change that is occurring to the Nissl substance that leads to the distribution and dispersal and redistribution of the Nissl substance. So Nissl substance is present in the cell body. It mainly consists of free ribosomes and rough endoplasmic reticulum. Okay. So this can also be asked, the composition of the Nissl substance. Okay. So you have to frame different questions from the explanations of particular answers, and only you can answer new questions. So next question is, aphasia is most likely associated with the lesion in. The options are Broca's area, sensory area, primary motor area, visual area. So the answer is Broca's area. Okay. So Broca's area is associated with the lesion called aphasia. So what is aphasia? Aphasia means loss of speech or change in speech. Either the person has difficulties in understanding or speech. Understanding or pronunciation, etc. Okay, not pronunciation, loss of speech basically. Okay, also the patient has difficulties in understanding the speech also. Dysarthria means difficulty in the articulation of speech. That's mainly due to the weakness of muscles involved in the articulation of speech. Okay, next is agnosia. That's the inability to understand the words or recognize a subject. Okay, aphasia means the patient cannot properly speak. And dysarthria means person can speak, but we cannot make out the speak made by the person because of the weakness in the muscles. And agnosia means the particular patient cannot understand the words or recognize a subject. So Broca's area is basically called the speech center. Okay. So this is another question. Broca's area is concerned with mainly word formation. Okay. So Broca's area is concerned with word formation. So next question, this is also very important. Which sensation is not lost on the side of lesion in Brown-Sequard syndrome? Brown-Sequard syndrome is asked in the recent NEET exam also. Okay. So basically, what is Brown-Sequard syndrome? It's otherwise called hemisection of the spinal cord. Okay. In particular, by Brown-Sequard lesion, there are some sensations which are lost in the ipsilateral or the same side, and some sensations are lost in the opposite side. Okay. So here they are asking about which sensation is not lost on the ipsilateral side in Brown-Sequard syndrome. The options are touch, vibration sense, muscle sense, temperature. So the answer is temperature. Okay. So basically, what is Brown-Sequard syndrome? That's the signs and symptoms which occur after the hemisection of the spinal cord that we will discuss later in this session. Okay. And crude touch, temperature, and pain sensations are affected on the contralateral side, i.e. when there is a lesion of Brown-Sequard occurring in a patient on the right side, patient feels pain on the left side or the contralateral side. Okay. Usually some penetrating injury and injuries like that cause this Brown-Sequard syndrome. Now, coming to the function of GABA in CNSs. The options are neuronal inhibition, neuronal activation, glial cell inhibition, glial cell activation. So what's GABA? GABA is an inhibitory neurotransmitter. So what is the function of GABA on CNS? It's the neuronal inhibition. Okay. So we have to know certain neurotransmitters, they are stimulatory or excitatory. So some of them are inhibitory. So you have to learn which of them are inhibitory. Mainly all of the neurotransmitters are they are excitatory, but there are certain neurotransmitters which are inhibitory. Okay. So this is also the same question framed in a different manner. Which of the following acts as a neurotransmitter inhibitor? Okay. The answer is, here is glutamate is a stimulatory or excitatory, aspartic acid, lysine. GABA is the inhibitory neurotransmitter here. Okay. So this table is very important. What are the inhibitory neurotransmitters? GABA and dopamine. You can remember by dog. Okay. Dopamine, DO and G, GABA. So dog is basically inhibitory. And acetylcholine and noradrenaline. Obviously, they are excitatory neurotransmitters. Acetylcholine is secreted in the end plate. Okay, end plate neuron. And noradrenaline, we know that it is usually occurring in, we have studied the sympathetic nervous system also. There also the neurotransmitter is noradrenaline. And it's mainly adrenaline and noradrenaline. They are responsible for the sympathetic action. So they are basically excitatory or stimulatory neurotransmitters. Okay. Next question is sympathetic stimulation causes. The options are arteriolar constriction, ciliary muscle contraction, sweat secretion, all of the above. So the answer is all of the above. These all functions are of sympathetic nervous system, or the sympathetic stimulation causes all these functions. Okay. So what are the basic functions of sympathetic division? And these are all classification of the ANS is sympathetic and parasympathetic division is there. Usually, just remember this thing. Normally, when in a relaxed or no stimuli or ideal state, what happens is only the parasympathetic system is firing. And when in emergency or the fight or flight response, only this sympathetic division is firing. So, we have to reduce the actions by remembering this basic point. Okay. So what happens is when the effector organ is a ciliary muscles are radial muscles. So they cause dilatation of the pupil. Okay. So during sympathetic stimulation, what happens is dilatation of pupil occurs due to the contraction of the ciliary muscle. So obviously parasympathetic relaxation of the ciliary muscle. Pupil dilatation in sympathetic and parasympathetic it constricts. Salivary secretion. What happens to salivary secretions? Usually dryness of mouth occurs due to sympathetic stimulation. We know that during Viva or exam time, we know that some dryness of mouth we can observe. Okay. So the reason for that is sympathetic division firing. And GI tract motility inhibition. Okay. Inhibition, and in parasympathetic, it's an acceleration. And GI secretion. Basically, secretions will increase in parasympathetic stimulation. Okay. Blood vessels, what happens is constriction, thereby increase in BP occurs. And bronchioles also dilatation. That's why the anti-asthmatic drugs are mainly sympathetic. Sympathomimetic drugs are also anti-asthma drugs also. Why? Because of the dilatation of the bronchioles, which will make the respiration easier. Okay. So, this is also a very important question. Sweat glands are supplied only by the sympathetic nerves. Okay. S for S, sweat glands. Usually, we know that when we are frightened or some emergency situation, what happens is we will sweat profusely. That's due to the sympathetic stimulation. Okay. So, sweat glands are supplied only by sympathetic nerves. Also, copious flow of watery saliva is secreted in response to normal stimuli. That's parasympathetic stimulation, not sympathetic, parasympathetic. Okay. Next question is, the pathway of pain from teeth and temperature is carried by corticospinal tract, corticocerebral tract, lateral spinothalamic tract, ventral spinothalamic tract. You have to learn which of the tracts are crossed and which are carrying sensations to the ipsilateral side also. That also you have to study. Okay. So the pathway of pain from teeth and temperature is carried by lateral spinothalamic tract, which is a crossed tract. Usually, this ascending tracts of spinal cord, they carry sensations to the brain. That's the ascending tracts are mainly carrying sensory outputs from the different organs towards the brain. Whereas descending tracts means what? They carry motor information from the brain to the effector organs or the muscles. Okay. So these are the basic functions of ascending tract and functions of ascending tract. First is the anterior spinothalamic tract. It's responsible for the crude touch sensation. as we cannot pinpoint where the touch is happening or the sensation is happening. We cannot exactly pinpoint, but crude touch sensation, that is the function of anterior spinothalamic tract. And lateral spinothalamic tract, pain and temperature sensation, that's crossed pathway. Okay. And spinothalamic, its function is subconscious kinesthetic sensations. And spinoreticular, it carries the consciousness and awareness. And spinovestibular, proprioception. Okay. Next is blood-brain barrier is absent in all of the following areas except. So what is blood-brain barrier? So basically our vessels or the arterioles, nerves, arterioles, venules, everything, they are formed by the lined by the endothelial cells. And in brain in particular, these endothelial cells are very tightly packed so that they won't allow any substance to pass in between. But in some areas of brain, the endothelial cells are not so tight. So they allow some passage of some amount of substance through them. Okay, there are 4 areas present in the brain which are devoid of blood-brain barrier. Okay, so here they are asking about blood-brain barrier is absent in all of the following except. That means what? Where the blood-brain barrier is present. Okay, so habenuclear trigon. So, which are the areas where outside the blood-brain barrier, which are outside the blood-brain barrier? They are posterior pituitary, area postrema, organum vasculosum of lamina terminalis, subfornical organ. This you have to learn by heart. Okay, which are the organs which are outside the blood-brain barrier, or not organs, parts of the brain. Okay, so they are collectively called circumventricular organs, and they have fenestrated or leaky capillaries, and they are permeable. Okay, that's why they are called outside the blood-brain barrier. So coming to the next question, the regeneration of nerve fibers is possible in the peripheral nervous system than the central nervous system because the options are presence of neurolemmal sheath in the peripheral nerve. Second is presence of neurolemmal sheath in the central nervous system. Third is absence of myelin sheath in the central nervous system and disturbed vascular supply. What's the answer? Answer is presence of neurolemmal sheath in the peripheral nerve. That's an important point. That's presence of neurolemmal sheath is responsible for the regeneration of nerve fibers, and hence it's present only in the peripheral nervous system and not in the central nervous system, and hence peripheral nerve fibers have the property of regeneration. Some amount of regeneration is possible. Okay, that's the reason. Now, which of the following things depend on the diameter of the nerve fiber? Diameter of the nerve fiber. The options are conduction velocity, duration of action potential, relative refractory period, spike potential. Which of them are responsible for the, dependent on the diameter of the nerve fiber? It's the conduction velocity. Okay, so usually this conduction velocity, the factors which affect the conduction velocity in a myelinated nerve fibers are fiber diameter, axon diameter, the myelin thickness, as well as the internodal length. Okay, and usually the conduction velocity is closely related to the fiber diameter and the myelin thickness. And the larger the diameter of the nerve fibers, obviously larger the diameter, the greater will be the conducting velocity. Okay. Also the myelin thickness also improves the conduction velocity. Next question is positive Tinel sign or Hoffman-Tinel sign means. Options are nerve regeneration, bone fracture at that area, orbital fracture, nerve damage. The answer is nerve regeneration. Okay. So, its otherwise called Tinel sign or Hoffman-Tinel sign. It was described by Paul Hoffman. It's usually, we refer to as just Tinel sign only. And it's the most commonly used test in the clinical evaluation of peripheral nerves. Okay, for the clinical evaluation of peripheral nerves. And it was used earlier as an indication of, earlier we used it as an indication of the start of nerve regeneration. Okay, it is used for the diagnosis of compression neuropathy such as carpal and cubital tunnel syndromes. And now it is replaced by electroneurographic diagnostic studies. They are serially carried out for the evidence of reinnervation. Okay, so this test is now not at all used nowadays. Now we are using electroneurographic diagnostic studies. Okay, so this is the diagrammatic representation of the Tinel sign. So what is tinel sign? How we demonstrate tinel sign? It's by the percussion over the divided nerve, resulting in the tingling sensation in the part supplied by the peripheral section. Okay, when we percuss over the divided nerve, there will be a tingling sensation by the on the part supplied by that particular divided nerve. Okay, that indicates what? That indicates the regeneration. Okay, now this test is no longer used. So, which nerve fiber is most commonly affected by hypoxia? A fibers, B fibers, C fibers, G fibers. What's the answer? That's a B fibers. Okay. So basically these peripheral nerve fibers are grouped based on the diameter, signal conduction velocity, as well as the myelination state of the axons. Okay. They can be divided into A, B and C types. Okay. So this peripheral nervous system, nerve fibers are divided based on the diameter, signal conduction velocity, as well as the myelination state. And fibers of the A group, they have larger diameter, high conduction velocity, and they are myelinated. So A and B are basically myelinated. And A group is again subdivided into alpha, beta, gamma and delta fibers based on the information carried and the tissues they innervate. They can be, A fibers can be again divided into alpha, beta, gamma and delta. And usually the fibers of the B group, they are also myelinated. So A and B are myelinated, with B is somewhat smaller in diameter when compared to the A fibers and have low conduction velocity, and usually they transmit autonomic information. And the fibers of the C group, they are unmyelinated, okay, and have smaller diameter and low conduction velocity. And C fibers, they are considered to be polymodal. Why? Because they respond to combination of stimuli like thermal, mechanical, chemical. They usually respond to combination stimuli. Okay, that's why they are called, C fibers are called polymodal. So which of the following is the, which of the fiber is polymodal? That's the C fibers. And A delta and C fibers, they contribute to the detection of diverse painful stimuli. And A delta fibers, they are responsible for the sensation of sharp because they are having high conduction velocity and having larger diameter. So they can sense sharp initial pain and respond to a weak intensity. Even a weak intensity of stimulus, it is responded by the A delta fibers. Okay. And so one thing we have to notice is that C fibers, this can be a potential question. C fibers are least susceptible to hypoxia and pressure because they are conducting very slowly. Okay, they are slow acting, so they have a low conduction velocity. And A fibers, they are least susceptible to local anesthetics. Why? Because they are very fast conduction fibers. Okay, very fastly conducting fibers, and hence local anesthetics have some time period to make its action. So they are very fast conducting. So A fibers are least susceptible to local anesthetics. So this is the classification by Erlanger and Gasser. That's the diameter. The diameter is largest in the A fibers, and high susceptibility to hypoxia is seen associated with the B fibers. That's what the question is asking. And C fibers, they have the least conduction. They are having high susceptibility to local anesthetics, whereas A delta fibers, they are least susceptible to local anesthetics. Okay. This can be asked as new questions. Now coming to the recent question. A patient is presented to the emergency after a road traffic accident. Right side, there is a loss of fine touch. Left side, there is a loss of thermal sensation and pain below the waist. What's the most relatable diagnosis? This we have already discussed. So the options are Brown-Sequard syndrome, paraplegia, syringomyelia, multiple sclerosis. What's the answer? It's a Brown-Sequard syndrome. Okay. So the other options, let's examine the other options. What is syringomyelia? It's a development of fluid-filled cyst within the spinal cord. When this cyst may enlarge and cause damage to the spinal cord, and the further lesions appear. And multiple sclerosis, as we have already discussed, it's an autoimmune disease causing demyelination of the neurons. Okay. So Brown-Sequard syndrome, it's an incomplete pattern of injury following a hemisection of the spinal cord resulting in weakness or paralysis, loss of proprioception and vibration sense on the ipsilateral, the same side, loss of proprioception and vibration happens, and the loss of pain and temperature sensation on the contralateral side. Okay. So when the patient is having a lesion on the right side, the patient is feeling the pain over the left side. Okay. So this is the Brown-Sequard syndrome, and below the level of the lesion, there will be impairment of ipsilateral light touch, proprioception, vibration. That usually it's affecting the dorsal columns, therefore causing this type of impairment. Okay, dorsal column pathways are responsible for light touch, proprioception, vibration from the site of the lesion caudally. That's towards the lower part. And impairment of the contralateral pain and temperature. That's due to spinothalamic tract. Okay, spinothalamic tract pathways are responsible for the pain and temperature. And since they are crossed, the impairment of contralateral pain and temperature occurs in Brown-Sequard syndrome. And also impairment of ipsilateral voluntary movements, usually the upper motor neuron type of paralysis below the level of lesion. And also there will be a temporary loss of vasomotor tone. And usually the prognosis of Brown-Sequard syndrome is good, and hence the patient will be, recovery of the patient is almost about 90% of the patients recover from this particular syndrome. Okay, now coming to the next question. A patient present with fluent speech for aphasia and characterized by neologisms that do not make any sense. That's uncommon words or without any meaning words. That's neologisms. Which area of the brain is most affected? The options are Broca's area, angular gyrus, Wernicke's area, arcuate fasciculus. So what's the answer? The answer here is Wernicke's area. Okay. So you have to learn this diagram by heart. Okay. What are the functions of different areas of the brain? Okay. So sensory cortex is usually associated with pain, heat, and other sensation, and parietal lobe, that's responsible for the comprehension of language. Temporal lobe, as we all know, from the position itself, we can assume it's related to hearing. Occipital lobe, that's a primary visual area, and frontal lobe, we have the smell sensations. Temporal lobe is responsible for the intellectual and emotional functions. Okay, brainstem, that's a medulla that is having many important functions. That's the swallowing, deglutition center. Okay, breathing, heartbeat, wakefulness center, and other involuntary activities. And cerebellum is usually associated with balance and coordination. And Wernicke's area, it's associated with speech and comprehension. That's what they are asking. Okay. Coming to the next question. Merkel cells, which is a mechanoreceptor involved in the touch sensation, they are primarily in which layer of the epidermis? So what are the layers of epidermis? So the layers of epidermis means the basal layer, that's a bottommost portion of the epidermis. Epidermis has got many layers, no? And the basal, undermost layer is the basal layer or the geminativum layer. Okay. And above the basal, we have the spinosum. That's a thicker layer. Okay. And above the spinosum, we have the granulosum, and above that, we have the corneum, stratum corneum layer. Okay. There is a layer called stratum lucidum in palms and soles alone. Okay. In normal epithelium, these are the layers, basic layers in the keratinized epithelium. Okay. So basically, Merkel cells, they are the mechanoreceptors. They are located in which layer? It's a basal layer. So Merkel cells as well as the melanocytes, they are located in the basal layer of the epithelium. Okay. And so these are the receptors responsible for various sensations. Mucinous corpuscles for touch, Merkel's disc for touch, and Puccinian for pressure, P4P, and free nerve endings. Pain do not have any particular receptors, but free nerve endings usually carry the pain. That's also frequently asked question. And Cross and bulb for cold sensation, and Raffinis end organ for warm sensation. Cross for make this C K, and you will remember. Okay, cross and bulb for cold. So this is another question. Puccinian corpuscles are major receptor for what? Pressure. Okay. So next question is the sensory receptors for pain are basically free nerve endings. There is no particular receptors for pain carrying. Okay. So next we can discuss some MCQs about cardiovascular system. Okay. So these are the high yielding topics in relation to CVS. So cardiac cycle you have to study. Different questions, many questions are asked from this particular area. And heart sounds, BP regulations, basically the chemoreceptors, baroreceptors, their location, etc. And ECG, different waveforms and their formation. Okay. So coming to the first question, the first heart sound is produced by the options are closure of aortic and pulmonary valves, the opening of aortic and pulmonary valves, closure of mitral and tricuspid valves, and opening of mitral and tricuspid valves. What's the answer? First heart sound is LUP sound. Okay. That's produced by the closure of mitral and tricuspid valves. That's between this mitral valves is the bicuspid valve or the mitral valve. Okay. So, this tricuspid valve is present between the right atrium and the ventricle, and mitral is the left side. Okay. So, this is another question. First heart sound occurs during which period? Okay. There are different phases of cardiac cycle. We know that. And in which period of cardiac cycle, the first heart sound, that's usually this first heart sound is produced by the closure of mitral and tricuspid valves. And occurs in which phase? That's the isovolumetric contraction phase. Okay, what happens is initially this atrial contraction or atrial systole occurs and the blood will be coming to the ventricle. Okay, initially the pressure in the ventricle is less than that of the atrium, and that's the reason why this atrium can load the blood towards the ventricle. Okay, when the pressure inside the ventricle is above the atrium, what happens is to prevent the backflow, this mitral and tricuspid valves will close. Okay, to prevent the backflow of blood. Also, the other valves, that is the aortic and pulmonary valves also, they are also closed. So, there is no way the blood can escape to the atrium or to the arteries or venules or the pulmonary artery or pulmonary veins like that. The blood is staying in the ventricle itself. Hence, ventricle, then in the next phase, what happens is the ventricle began to contract. And ventricle began to contract and the pressure inside the ventricle will rise. But all the valves are closed. And hence, ventricle is contracting in a closed volume. That's why it is called the isovolumetric contraction phase. Okay. So, first heart sound. This is very important. This table is very important. I will explain. Okay. So, the first heart sound, it is due to the closure of atrioventricular, that's a mitral and tricuspid valves simultaneously. Okay. The systole is not happening only in the right or left side. It's occurring in the combined, that's right and left side consecutively, simultaneously it is occurring. That's why it's the closure of AV valves, that's a mitral and tricuspid valves simultaneously results in the formation of first heart sound. So what's the characteristics of first heart sound? It's a long, soft, low pitched and sounds like a LUP. It's a long sound. Okay. It is produced during the isometric contraction and the earlier part of the ejection period. And now coming to the second heart sound, it is due to the, so the first and second heart sounds, they are basically due to the closure of valves. Okay. First heart sound is due to the closure of AV valves, that's a mitral and tricuspid valve simultaneously. And the second heart sound, it's due to the closure of semilunar, that's a pulmonary and aortic valves simultaneously. Okay, so these two sounds are due to the closure of different valves. And the second is S for S, that's a short, sharp, high-pitched sound, high-pitched, and it sounds like a dub. Okay, that is shorter in duration. It's a sharp sound and a high-pitched sound in contrast to the first heart sound. Okay, and it sounds like a dub. And it is usually produced during the onset of a diastole. Okay, before, just during the onset of diastole, this second heart sound occurs. And the third heart sound and fourth heart sound, they are not audible by the stethoscope. Okay. And third heart sound, it is produced during the rapid filling period and it is usually inaudible by the stethoscope. And fourth heart sound, that's also inaudible and it is produced during the atrial systole. So we have to study which phase this sounds are occurring and also due to what the sounds are occurring. In first and second heart sounds, they are due to the closure of different valves. Okay. And third and fourth heart sounds, they are inaudible. Now, another question. Second heart sound is characterized by all except due to the closure of semilunar. Of course, it is due to the closure of semilunar and aortic valves. It's occasionally split. Yes, of course. It has a longer duration. No, it is having a short, sharp. It's a short, sharp sound. Okay. And fourth is, it marks the onset of the diastole. Okay, so here the answer is it has a longer duration than the first heart sound. It's the wrong option. Okay. So the answer here is third. Okay. It's usually short duration, sharp and high-pitched sound. So coming to the next question. The ventricular repolarization ECG is best seen. The options are P wave, Q wave, R wave, T wave. So what's the answer? T wave. Okay. So this also you have to remember. Numerous questions are asked. In the last PSC exam also this question was asked. Okay. Then the PSC question was like this. From this line, this QRS complex. It is due to the ventricular depolarization. You remember it like that. This ADIP, atrial depolarization, P wave, and VERIT, ventricular repolarization, T wave. It is causing the T waves. And the other one, QRS complex, that's due to the ventricular depolarization. This you have to study well. Okay. This can be asked again. Next question. All the heart valves are open during which stage of the cardiac cycle? All the heart valves are open. Systolic ejection, isovolumetric relaxation, isovolumetric contraction, none of the above. One thing, one short tip you have to remember is either it is isovolumetric relaxation or isovolumetric contraction. None of the valves are open. Okay. That means what? Isovolumetric means the volume is a constant. Hence, it should be either in the ventricle or in the atrium or any closed chamber. No outways or outflows should be allowed. So that's why it is called isovolumetric. The volume is maintained. So in isovolumetric, either it is relaxation or contraction, whatever it is, the all the valves are closed during that phases. Okay. So here the answer is none. So these are the events, basic events of the cardiac cycle. So first is the atrial systole, in which the atria contract and small amount of blood enters the, by the contraction of atria, what happens is small amount of blood that enters the ventricles, and AV valves are open. Of course, from there itself the blood is flowing towards the ventricle, and AV valves are open and the semilunar valves are closed. Okay. And outflow is closed, only inflow is maintained in the atrial systole, and duration is about 0.11 second. Even they can ask this also. Okay. So next is isometric contraction. So what I have already said that the whole valves are closed in isometric. Okay. Whether it is isometric contraction or it is isometric relaxation. Okay. Second step is the isometric contraction. That is, the ventricle is contracting and the pressure inside the ventricle is raised, and hence to prevent the backflow, what happens is AV valves are closed. Okay. The mitral and tricuspid valves are closed, producing the first heart sound. Okay. So the duration of this particular phase is about 0.05 seconds. Next is the ejection phase. The semilunar valves, the outflow is open. Third phase, what happens is the pressure inside the ventricle is raised than the aorta or the pulmonary artery. What happens is the semilunar valves are opened and the ventricles contract and the blood is ejected or forcefully ejected into the aorta as well as the pulmonary artery, and this period lasts for 0.22 seconds. Okay. Next is a protodiastole. That is, the semilunar valves are closed. Okay. After flowing into the aorta and the pulmonary artery, what happens is semilunar valves are closed. Why? In order to prevent the backflow. Okay. So that's what we call as protodiastolic. And the duration of this particular period is about 0.04 seconds. Next phase is the isometric relaxation. So here also all the valves are closed and the pressure inside the ventricles is reduced, and the duration is only 0.06 seconds. So basically, this is a brief summary of this cardiac cycle. This you have to learn it very well. Okay. This CVS topic, this cardiac cycle is very important. That's the basics. Okay. And next is the rapid and slow filling. There the AV valves are open and the ventricles relax and the filling occurs. And the duration is only about 0.3 seconds. Okay. Coming to the next question. Cardiac output is not affected by. First option is the heart rate, peripheral resistance, systolic blood pressure, venous return. What's the answer? So the answer is systolic blood pressure. So what is cardiac output? It's the amount of blood pumped by the heart in a minute, 1 minute. Okay, amount of blood pumped by the heart in 1 minute is what we call as cardiac output. That's the basic definition of the cardiac output. So by knowing that cardiac output is the measurement of first option peripheral resistance into tissue fluid, second option is peripheral resistance into cardiac rate, blood pressure into cardiac rate, heart rate into blood volume. So what's the answer here? What is cardiac output? It's the amount of blood pumped by the heart in 1 minute. Okay. So what is cardiac output? It's the heart rate into blood volume. Okay. So the answer here is heart rate into blood volume. So basically, these are the factors affecting the cardiac output. That's a venous return. The force of contraction of heart. When the heart is contracting very forcefully or the myocardial contractility is high, what happens is cardiac output will be increased. When the venous return to the heart is high, then also cardiac output will be increased by the Frank-Starling's law. Okay. And the frequency, when the heart is beating very frequently, then also the cardiac output may be increasing, and also the peripheral resistance. Okay, peripheral resistance will reduce the cardiac output. Okay. So, the following factors increase the cardiac output except. The options are preload, afterload, heart rate, myocardial contractility. The answer is afterload, obviously, and afterload is a factor which do not increase the cardiac output. Why? Preload means basically the venous return. Okay, for the filling, blood filled in the ventricles. Okay, that's what we call as preload before the cardiac contraction. And afterload, that occurs in the arterioles, and the heart rate means the pumping action of the heart. Okay, and myocardial contractility means the pumping action of the heart. So, next question. The largest function of the total peripheral resistance is due to. The options are venules, arterioles, capillaries, precapillary sphincters. The answer here is arterioles. Why? Because arterioles are having less diameter. Okay, among this options, the arterioles having the least diameter. Hence, peripheral resistance. Peripheral resistance is the resistance offered against the blood flow. Okay, so it is inversely proportional to the diameter of the blood vessel. Okay, so total peripheral resistance is indirectly proportional to radius of the vessel, and radius is minimum in arterioles, and hence the total peripheral resistance is maximum in arterioles. Okay. It's the same question again. Peripheral resistance is maximum in arterioles. Okay. Next is the Starling's law of heart. The options are does not operate in a failing heart, does not operate during exercise, explains the increase in cardiac output that occurs when the venous return is increased. And the fourth option is explains the increase in cardiac output when the sympathetic nerve supplying the heart is stimulated. So here nothing to do with the sympathetic and parasympathetic, because in the coronary circulation is not dependent on any type of things. Okay, this is very important. Not the coronary as well as the brain circulation. That's not dependent on any sympathetic or parasympathetic innervations. Okay. They are autonomic circulations. Coronary and brain circulations, CNS, central nervous system circulations, they are not dependent on this autonomic nervous system. Okay. So here the answer is, it explains the increase in cardiac output that occurs when the venous return is increased. Okay, that's the answer here. So what is Starling's law basically? Starling's law of heart means it increase in force of contraction is directly proportional to cardiac output. That is, when the force with which the heart is contracting is increased, cardiac output or the amount of blood ejected in 1 minute is increased. When the heart is contracting very forcefully, this cardiac output will be increased. So it is the force of contraction is directly proportional to cardiac output, and the force of ventricular contraction is also proportional to it's directly proportional to the end diastolic volume. That is the amount of blood in the ventricle. When the amount of blood present in the ventricle is more, that causes the tension in the muscle fibers that will lead to increase contraction, and the force of ventricular contraction is also increased when there is an increase in the end diastolic volume. So what is preload? Basically, what is preload? Preload is the stretching of cardiac muscle at the end of diastole. Okay. At the end of diastole, the stretch of cardiac muscle is what we call as preload, and it depends upon the venous return as well as the ventricular filling. And the force of contraction of the heart and cardiac output is directly proportional to preload. Preload means at the end of diastole, that's before the heart start pumping or the contraction, the stretching of cardiac muscle is what we call as preload. So when the venous return and the ventricular filling is more, what happens is stretching of cardiac muscle will be more. That causes the increase in force of contraction. That's what we call as Frank-Starling's law. And what is afterload? Afterload means it is a force against which the ventricles must contract and eject the blood. Okay, there will be a resistance in the vessels or the arterioles and the blood vessels, which offers resistance to the flow of blood. Normally, it prevents it, don't like the flow of blood. And so there is a resistance offered by them. Okay, so afterload is the force against which the ventricles must contract and eject the blood. And the afterload for the left ventricle is determined by the aortic pressure, and afterload for the right ventricular pressure is determined by the pressure in the pulmonary artery. They are outflow systems. If they are offering more resistance, what happens is ventricle has to contract more forcefully in order to pump the blood through this pulmonary artery as well as the aorta. When these are having high resistance, afterload will be higher. Okay, so the force of contraction of heart and cardiac output will be indirectly proportional to the afterload. When the afterload or the resistance offered is high, what happens is heart has to pump very forcefully, and this will reduce the cardiac output. Okay. This is what we call as Frank-Starling law of heart. That's the force of contraction depends on the diastolic period, ventricular filling, preload, as well as the afterload. Now, next question. This is also very important. You have to know this all names. Okay. First is a chronotropic effect. Second is a dromotrophic effect, bathmotropic, and ionotropic effects. You have to be very clear with these terminologies. Okay. So, effect on the force of contraction of heart is ionotropic effect. Okay. So, these are the different terminologies. Chronotropic means chronology means something related to rate. Okay. So, effect of heart rate is chronotropic action. Ionotropic means force of contraction. We know that this nerve conduction, everything depends on some ions. Okay. So, you can remember it like that. Ionotropic action means the force of contraction. Force of contraction. Effect on force of contraction is what we call as ionotropic. Different drugs having this type of actions. Okay. So, you have to be very clear with this terminologies. Next is the dromotropic action. So, it is the effect of conduction of impulse. Impulse through the heart is what we call as dromotropic action. Next is the bathmotropic action, which is the excitability of the cardiac muscles. Okay. Coming to the next question. Stimulation of baroreceptor leads to. So what are baroreceptors? Baroreceptors in general means pressure receptors. Okay. So they measure the pressure, blood pressure. Every time they measure the blood pressure, and after measuring the blood pressure, when it is seen to be high, what happens is it alerts the cardioinhibitory centers, thereby reducing the blood pressure as well as the heart rate. That's the function of baroreceptor. Okay, so the here answer is decreased BP and decreased heart rate. Okay. So what's the function of carotid body? Carotid body is a chemoreceptor. So what's its function? It measures the change in PO2 in arterial blood, measures the PO2 in venous blood, measures the change in carbon dioxide in arterial blood, measures the change in carbon dioxide in venous blood. What's the answer? The answer here is measure the change in partial pressure of oxygen in arterial blood. Okay. So rapid increase in the arterial blood pressure that I already explained. That's a rapid increase in the arterial blood pressure that leads to baroreceptors in the carotid sinus get stimulated. They stimulates the cardioinhibitory center and suppresses the vasomotor tone, thereby reducing the blood pressure. And heart rate, force of contraction and peripheral resistance, they are all decreased, and cardiac output and arterial blood pressure are reduced. and thereby leading to, and after their action, that's the reduction in BP and heart rate, this baroreceptors will be inactivated. So further stimulation and the pressure will not be there. So this function is inactivated. Okay. So what's the location of carotid body vasoreceptor? It's located in the origin of, this is also very important, this location. Okay. It's located in the origin of internal carotid artery. Also, they are present in relation to the wall of arch of aorta. Okay. This you have to keep in mind. They are located in the origin of internal carotid artery. Also, they are found in the wall of arch of aorta. So, what are Trobe-Herring waves? Trobe-Herring waves are, they are fluctuations in the blood pressure which are synchronized with the respiration. Along the waves of respiration, the blood pressure variation occurs. That's what we call as Trobe-Herring waves. Next question. Cardiac contractility is regulated by. The options are end diastolic volume, end systolic volume, myocardial muscle wall function, thickness of muscle wall. So the answer here is end diastolic volume. This I have explained many times. So basically this is the Frank-Starling's law. The length tension relationship of the cardiac muscle, it is similar to that of a skeletal muscle, normal skeletal muscle, is similar to that of a cardiac muscle, that length and tension relationship. Okay, when the muscle is stretched to a particular extension, what happens is the developed tension will be increased proportionately till a particular maximum. And after that, even we are stretching beyond that particular limb, then this tension will not be there. Okay, this tension will not increase after crossing a particular limit. And Starling pointed that this is called the energy of contraction is proportional to the initial length of the cardiac muscle. So initial length of the cardiac muscle. So this contraction is proportional. When the initial length of cardiac muscle is more, then the energy of contraction will be less. Okay, basically. So stretching, when stretching increases, initial length increase means stretching, further stretching is only reduced. Okay, initial length is more, then the force of contraction will be reduced. If the initial length is less, when we stretch it to a particular extent, the tension in the muscle will be raised up to a particular point, and further increase in the stretch of the muscle fiber will not cause any further increased tension. Okay, that's what we call as Frank-Starling's law. And for the heart, the length of muscle fiber, i.e. the extent of preload, it is proportional to the end diastolic volume. Okay, i.e. more amount of blood is present, that will cause the more stretching of the muscle, and that will lead to increased contraction, and it will lead to increased cardiac output. Okay. So the length of the muscle fiber for heart, the length of the muscle fiber, i.e. the extent of preload, it is proportional to the end diastolic volume, i.e. the amount of blood present in the after the diastole. In cardiac cycle, the pulmonary valves open when? The options are end of diastole, beginning of systole, end of isovolumetric relaxation, end of isovolumetric contraction. So the answer here is end of isovolumetric contraction. Okay. After the isovolumetric contraction, what happens is pulmonary valves open and the blood will be ejected out through the pulmonary valves and the aorta. Okay. I have said that during the isovolumetric contraction, all the valves are closed. So these are the valve status. Okay, during the atrial systole or the inflow phase, what happens is AV valves are open. Okay, from where this blood is flowing into the ventricle. And semilunar valves, that is aortic and pulmonary valves, they are closed. And what happens is atrial contraction. Atrial contraction is occurring, the blood is filling the ventricle through the AV valves. So these AV valves are open in the atrial systole and the semilunar valves are closed. And next phase is the isovolumetric contraction. Here, this blood reached the ventricle, and after that, AV valves are closed. Why? Because in order to prevent the backflow of blood to the atrium, this AV valves are closed. And semilunar valves of the aortic are also closed, and the ventricles began to contract in a closed space. That's why it is called isovolumetric contraction. Next phase is the ventricular ejection. There, To prevent the backflow, what happens is ventricular pressure will be more, and hence to prevent the backflow, these AV valves are closed, and due to the pressure difference in the aorta and pulmonary artery, what happens is the pressure is less in aorta and pulmonary artery, and therefore this aortic and pulmonary valves are open and the blood is ejected. Okay. So the pressure in the left ventricular pressure is more than that of aortic pressure, and hence the blood flows towards the least pressure side, that's towards the aorta. Also in the right ventricular, pressure is more than the pulmonary arterial pressure, and hence the blood is ejected to the pulmonary artery. And next phase is the isovolumetric relaxation. Here also all the valves are closed and the semilunar, every valves are closed. Okay, next is the ventricular filling. Here the AV valves are open, and after that semilunar and aortic and pulmonary valves, they are closed and the ventricle is finally relaxed. Okay. Next question. A 65-year-old male patient visited to the doctor for chest pain, and on examination his BP was measured as systolic BP is 190, diastolic is 100, and the difference, that's the pulse pressure, is 90. Okay, heart rate is normal only. And decrease in which of the following explains the high pulse pressure? So the options are arterial wall compliance, stroke volume, cardiac output, myocardial contractility. What's the answer here? So here the pulse pressure is widened. Okay, normal pulse pressure is about 40 mm of mercury, but here it is 90, and also systolic and also the systolic and diastolic BP both are elevated. Okay, so what is the reason for this high pulse pressure? The answer is arterial wall compliance. Okay, so the pulse pressure means what? The force that heart generates each time. When the heart is contracting, the force it is producing, that's what we call as pulse pressure. Okay. When it contracts, the force it is producing, that's what we call as pulse pressure. Okay. So aging basically impacts the pulse pressure and arterial compliance. Okay, with aging, the decrease in compliance of the large elastic arteries. That is, the large elastic arteries, what happens is the elastin protein, or the protein which is providing the elasticity of the arteries will decrease. Also, the collagen deposition will be more. So, arteries cannot contract or relax. The hardening of arteries occurs. Usually, the arteries are very elastic. Okay, but due to aging and due to atherosclerosis and things like that, due to aging itself, the elastin content will be reduced and the collagen 1 deposition will be more, the heart arteries will be hardened. So heart has to exert more force. More force has to be exerted by the heart, and hence the widening of pulse pressure occurs. Okay, so as the left ventricle contracts against the stiffer or less compliant arteries, the systolic diastolic, it has to exert more force or more pressure. Okay, in order to contract against the stiffer arteries. So widen pulse pressure occur, and also it will lead to left, due to the increased function, what happens is left ventricle tends to undergo hypertrophy. Okay, what is hypertrophy? The enlargement of cells. Okay, hyperplasia means number of cells will be increased. And when excessive pulse pressure transmits through the microcirculation of the vital organs such as brain and kidneys, okay, extensive tissue damage. Why extensive tissue damage? Because proper blood supply is not reaching the brain. Because ventricle has to exert more pressure in order to make the blood supply adequate for the vital organs. Okay, more force. Thereby it will cause ischemia of the vital organs. Proper blood supply is not getting to the vital organs. A widened or large pulse pressure occurs during several diseases including aortic regurgitation, aortic sclerosis. Okay, severe iron deficiency anemia. Okay, in severe iron deficiency anemia also, this is happening. There is a hyperdynamic circulation. Why hyperdynamic circulation? Proper amount of oxygen carrying capacity of the hemoglobin is reduced due to iron deficiency. Okay, hemoglobin amount that's as such is reduced. So heart has to pump very fast in order to provide adequate amount of oxygen to all the vital tissues. Heart has to pump very fast, and the heart rate should be increased, and pounding pulse rate will be high. Okay. That's a cause in severe iron deficiency, hyperdynamic circulation. This occurs in the Paget's disease and diseases like that also. This hyperdynamic circulation occurs. Next question. It's a recent NEET MDS question. A patient collapses and loses consciousness and then he recovers. Diagnosis shows complete heart block. Identify the related disorder. The options are Wolff-Parkinson-White syndrome, Stoke-Adams syndrome, myocardial infarction, sixth sinus syndrome. So what's the answer? It's a typical presentation of Stoke-Adams syndrome. So what is Stoke-Adams syndrome? During a Stoke-Adams syndrome attack, total AV block suddenly begins and the duration of block may be variable. It may occur again in few seconds it will cease, or even it may take several weeks also. Okay. So total AV block causes the patient to lose consciousness. And what is Wolff-Parkinson-White syndrome? It's a congenital condition characterized by the increase in heart rate. It is due to the increased signaling pathways between the atria and ventricles. There will be increased signaling pathways thereby leading to higher heart rates, more than 100 in individuals having this Wolff-Parkinson syndrome. It's a congenital syndrome. Now coming to the muscles and neuromuscular junctions, only few questions are provided. These are the high-yielding points, high-yielding topics. The types of muscles with image-based questions can be asked. Okay, different types of muscles, skeletal muscle, smooth muscle, cardiac muscles and their properties. And the properties of the muscle movement, rigor mortis, Frank Starling's law, we have already mentioned. Muscle spindle and Golgi tendon organ. And next is a nerve conduction, i.e. the neuromuscular junction is also a very important topic regarding to this particular topic. Coming to the questions. First question is, rigor mortis results after the death due to? The options are failure of acetylcholine to diffuse, failure of ATP supply. Third option is a failure of breakdown of calcium bridges. None of the above. So what's the answer? The answer is failure of ATP supply. So why this ATP supply failure cause rigor mortis? What is rigor mortis? At death, all the muscles of the body undergo severe contraction. All the muscles undergo severe contraction and they become rigid. That's what we call as rigor mortis. Okay, it's due to the loss of ATP. So what is the purpose of ATP in muscle contraction? After the muscle contraction, in order to separate the cross links, the cross bridges formed between the actin and myosin components of the muscles, we need ATP. Okay, so after death, we have loss or depletion of ATP. So the cross bridges are not separated and hence the permanent contraction of muscle occurs in all parts of the body without any relaxation. That's what we call as rigor mortis. So next question, this is also very concept-based question. You have to learn about the action potential also. Okay. True about the hyperpolarization of membrane in neuron conducting impulses. The options are inhibitory action, stimulatory action, no effect, short-term fasciculations. So what's the answer? It's an inhibitory action. Why it is inhibitory action? So what is an action potential? Action potential means it's a short-term change in the electrical potential that travels along a cell, such as nerve or a muscle fiber, and allows the nerves to communicate. Okay, so we know that in between a neuromuscular junction, what happens is acetylcholine is usually released. Acetylcholine is a chemical neurotransmitter. Okay, so this chemical stimulation is converted to electrical impulses. Okay. This chemical impulses is converted to electrical impulses in action potential. So this chemical neurotransmitters, they are used to convey the information from the neuron to the muscle. Okay, that is between the muscle fibers and nerve fibers, this action potential is occurring and it is leading to the transmission of impulses from one neuron to next neuron. But within the neuron, these potentials, these impulses are transmitted as electrical changes. That's what we call as action potential. So action potentials are occurring inside a particular cell and in between cell, this chemical neurotransmitters are used for the passage of information. Okay, so when we know that what are the parts of a neuron? The parts of neurons consist of basically this dendrite, cell body, axons, etc. Okay, so when a neurotransmitter is released, what happens is that ligand-gated ion channels open. Ligand-gated ion channels means something in response to a ligand. Here it is a chemical neurotransmitter. So ligand-gated channels open and the entry of different ions occur, not a particular ion. different ions can occur. Okay, so basically within the cell there are potassium and different anions. That's basically a negative potential is present inside the cell, and outside we have different ions like sodium ions, calcium ions, etc. Calcium ions and positive ions are more common, more seen in the outer environment. And the intracellular environment, they basically consist of potassium and other anions. When a chemical signal is received, what happens is ligand-gated ion channels can open, and that will lead to entry of different ions inside the cell. It can be different positive ions like calcium ions, sodium ions, etc., leading to inside the cell we have an electronegative potential. Usually, say it's minus 70 millivolt. Different cells, different potentials are there. So, for example, just assume that the potential is minus 70. Then what happens is after the release of neurotransmitters, this ligand-gated channels open and the entry of some positive ions occur. So, when positive ions are entering more, what happens is the electronegativity of the cell will be reduced. That will lead to depolarization. That's the first step, depolarization. That's the electronegativity of the cell is decreased. When that's what we call as in a single dendrite, this is called excitatory postsynaptic potential, EPSP. Okay. When the negative ions are entering, what happens is the negativity inside the cell also again increase. That will lead to hyperpolarization. Or since electronegativity is increasing, it's always called repolarization also. That's the main cause in this hyperpolarization. Hyperpolarization means the increased electronegativity inside the cell due to the entry of maybe sometimes chloride ions are entering more inside the cell. That will lead to the hyperpolarization. In hyperpolarization, what happens is we require more positive ions or more stimulation is required to stimulate the particular neuron. So hyperpolarization is a phenomenon required to, it's an inhibitory to neuronal transmission. Why? Because there is more electronegativity inside the cell and hence require more stronger stimulus to excite the particular cell. So it's an inhibitory phenomenon. Okay. When this EPSP occurs in different neurites collect the EPSP, and a particular EPSP that is called the threshold potential that will cause the voltage gated sodium channels to open. Okay, that will lead to the passage of impulse throughout the neuron and the conduction of the nerve. That's what we call as firing of neurons. Okay, neuron gets fired due to the increased EPSP that will lead to the threshold potential. It may raise to from negative 72, it may raise up to plus 40 or something like that. Okay, that is what we call as threshold level. After the threshold level, this information is continued inside the cell. And after that, this voltage gated sodium channels are open, and after a particular period, they will get closed or it get inactivated. That's what we call refractory period. During the refractory period, we cannot further excite the neuron. That's a protective phenomenon. That is, it helps to prevent the action potentials from occurring too soon. Also, the backward flow of information is also prevented by the refractory period. Okay. So that's about the action potential. So this is the diagram. So this is the membrane potential. Initially, it is around minus 70 in the resting state. Inside the cell, there is minus 70 millivolt. And during the depolarization, that is during the entry of this positive ions and EPSP up to a particular point, this point is called the threshold area, threshold potential. That is multiple EPSPs in a neuron cause the membrane potential to rise up to about minus 40. And after that, this sodium channels will be closing. That will lead to repolarization. That is a negativity. That is potassium channels also open later. And due to the diffusion of the potassium ions from inside the cell to outside, what happens is potassium is a positive ion and hence the negativity will further increase. Also, we know that sodium potassium transmission, 3 sodium ions are pumped inside and 2 potassium ions are pumped outside. Okay, that also will lead to some amount of repolarization. Repolarization means the electronegativity is again, electronegativity is again reinstated. That will lead to repolarization. And sometimes, even after the inactivation of the sodium channels, these potassium channels continue to eject potassium from inside the cell to the outside. That will lead to an undershoot. That is, electronegativity will be more further than the resting membrane potential. The electronegativity will be further increased. That will lead to the hyperpolarization. And after some times, these potassium channels also close, leading to the restoration of the potential to the resting state. Okay. So this is in summary. The resting state, no ions are moving through the voltage gated channels. Okay, voltage gated channels require some amount of threshold potential to open. Okay, next is the depolarization. It is caused by the sodium flowing into the cell. Sodium ions are flowing into the cell. So the electronegativity is reduced. That's what we call it. More polarization means what? The electronegativity is high. In order to reduce the, when the electronegativity is reduced, that is what we call as depolarization. And repolarization, again, it is caused by the potassium flowing out of the cell. That is, electropositive charges are flowing outside, and hence the electronegativity is further reduced, leading to repolarization. Okay, and hyperpolarization is also caused by the, again, even after the inactivation of the sodium voltage gated sodium channels, this potassium is continuing to leave the cell. Also, the sodium potassium channels are also playing into action. This will lead to hyperpolarization, that is reduction of resting membrane potential further. That is, electronegativity in the cell is again reduced, again increased. That is from -70 to some -90. Okay, in that particular stage also, further excitation of the neuron will not take place. So after the completion of action potential, the sodium gates remain closed. So no initiation of AP occurs. That's what we call as refractory period. So hyperpolarization, the function is to prevent the neuron from receiving another stimulus, or it raises the threshold for a new stimulus. Okay. So coming to the next question, the skeletal muscle activity, it is dependent on. The first option is the motor neuron. Second is impulses generated from the muscle end plate. Third is the skeletal muscle activity, contraction initiated by calcium binding to tropomyosin. Fourth is the spread inward to all parts of the muscle via the tubule system. The answer is skeletal muscle activity, contraction initiated by calcium binding to tropomyosin. Okay. So what is the skeletal muscle activity? Basically, there are different units. Okay. So 80% of the content of skeletal muscle consists of long bundles of proteins, which are called myofibrils. And this myofibrils consists of two types of myofilaments. One is the thick filament, which is containing myosin. And second is the thin filament. It consists of three proteins. One is the structural protein, which is called actin. It can form bonds with the myosin. And a protein called tropomyosin. And the third protein, which is calcium binding troponin, which regulates the position of tropomyosin. Okay, so basically this myosin heads are located in the thick filament, and it has a tendency to bind to the actin, the component of actin which is called F-actin. Okay, it has a natural tendency to bind with actin, but the myosin binding site of actin is covered by a particular protein which is called tropomyosin. When calcium is released from the sarcoplasmic reticulum, from the L tubules, what happens is this calcium binds to the C component of the troponin, and it will lead to the some change in troponin, which causes the tropomyosin to move back and unlock the sites or unhide the sites of myosin binding in the that is present in the actin. That is, actin is having a myosin binding site which is covered by the tropomyosin. And when the calcium binds with the troponin C part, when the calcium bind with troponin C, what happens is the tropomyosin will be removed from the myosin binding sites of actin, thereby causing the interaction of myosin heads with the actin, leading to muscle contraction. Okay. So when the myosin head is there, what happens is myosin when binds to the actin, there is ADP and phosphate present in the myosin head. When it is bound to actin and cause muscle contraction, what happens is initially the ADP is released and then the phosphate is released, and it will combine to form ATP. That is, ATP is formed outside during the muscle contraction. Okay. When actin and myosin cross bridges are formed, it will cause the thick filaments to move the thin filaments towards the center, and the sarcomere, so the functional unit of the muscle, will shorten. That's what happens in the muscular contraction. Okay. So, two myofilaments are arranged in myofibrils in distinctive repeated structures which are called sarcomeres. And each sarcomere consists of thin filaments. Okay. During muscle contraction, when actin and myosin cross bridges are formed, what happens is the thin filaments, these thin filaments are moved towards the center and the muscular contraction occurs. That's what we call as sliding filament mechanism of muscle contraction. And that's why when ATP is formed outside, during the muscle contraction, this phosphate and ADP is released outside and they combine together to form ATP. And this ATP is, this energy is used to restore the myosin head and uh, 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 separate the cross links formed between the myosin and actin head. Sorry, actin, myosin head and actin, and thereby restoring the normal muscle. Okay, that's leading to muscle relaxation. That's why, due to depletion of ATP during death, this rigor mortis or the permanent contraction of muscles occur due to the depletion of ATP. There is no ATP, and hence this myosin and actin filaments are bound together, and the cross links or cross bridges will not be broken and they remain contracted. That's why rigor mortis occur. That's the basic mechanism of muscular contraction. Three things are there: actin, myosin, and tropomyosin. Tropomyosin is the covering thing, and calcium binding to the troponin C will lead to the unhiding of the sites masked by the tropomyosin, thereby leading to the actin and myosin interaction. Okay. So when signaled by a motor neuron, the skeletal muscle fiber contracts and the thin filaments are pulled and then slide past the thick filaments within the fibers sarcomeres. That's what we call a sliding filament model of muscle contraction. And the sliding can only occur when the myosin binding sites on the actin filaments, they are exposed by a series of steps that begins with calcium entry into the sarcoplasm. Okay. So that's what the question is asking about. Okay. So skeletal muscle activity is dependent on the skeletal muscle activity contraction. It's initiated by the calcium binding to the tropomyosin. So that's all about this thing. And you have to study well this high yielding topics. You have to learn very well. Okay. There are many more questions that you have to learn. And if you have any doubt, you can ask in the WhatsApp group. Okay. So thank you for the patient listening. Good night.